an issue, even subcutaneous denosumab is all fine. Next slide. Go to myeloma, please. Yeah. Transplants, as I said, myeloma autografts, unfortunately, they're the least toxic transplants, but we will be able to start after some time. But for the time being, maybe till we know the India's pattern, I think for the next month or so, it will be a good idea to postpone them. Just continue with whatever the schedule of drugs has been going. Maintenance, not a problem at all. Most of the Indian patients will be somewhere in the range of 10 to 15 milligram of lenalidomide. If it is so, okay, but some patients may be on 20 and 25 milligram also. I think that's a good time to reduce the dose of lenalidomide to around 10 mg in these patients at this point. If somebody relapses, it's really bad. There are people saying that if it's very poor prognosis, you feel salvage is very, very tough, just put them on oral medications, even oral melphalan for that matter, at low doses, or all the imids and everything. But if you feel it's a salvageable patient, maybe weekly single dose protocol, carfilzomib is all fine. Carfilzomib day 1, day 2 used to be the protocol, but even we can give a 60 mg stat or a flat dose on day 1, 8, and 15. So that is also one salvage protocol we can think of at this point in time, and give a 2-week off so that we will cover 5 weeks of therapy with just 3 hospital visits. That also, first day you admit the patient, procure all the drugs. The next day 8 and day 15, just do it as a daycare kind of a thing with a short in and out of the hospital. That is on. So next slide. So this is about some myeloma cases who had COVID and they used this tocilizumab to treat these patients. So I'm not going to the details for want of time. Next slide. Yeah, coming to benign hematology, not much. Most of the patients, I will say, try to manage it on a telemedicine consultation basis itself. But there may be some really, really bad cases who may end up with you. One among them is, next slide, please. Aplastic, yes, aplastic at this point, anytime up to 45 or 50, transplant is the best option. But unfortunately, we are really, it's a heavy transfusion dependent therapy, I should say, because we need to have a lot of transfusion, let it be ATG or transplants or whatever. But ATG still a viable option, provided you can get it, all the logistical issues are sorted out for getting ATG. You can very well use it, but we all know it's a transient lymphopenic drug. So some cases of other viral reactivations are noted in ATG, but how far it will have an effect on COVID, we really don't know. But if feasible, nothing wrong, 4 days of SDP, collect 3 or 4 donors, divided into 2 to 2. Every time with ATG for 4 days alone, just try to give this SDP with ATG or whatsoever. So that's very well feasible. But if you feel that the aplastic anemia is not a very severe one, that is TLC is more than 200 and the patient is relatively salvageable, if you feel that way, I think a simple oral regimen of cyclosporin, low dose cyclosporin, L-thrombopag, and plus or minus danogens is also very much feasible. Because arranging the finances for ATG at this point sometimes may not be feasible for every patient. But not wasting much time, this protocol may be started. There are trials already going on with L-thrombopag and cyclosporin. The results are yet to come. But I think this is the time maybe we can try our hand with this oral combination of drugs for aplastics. But as we know that GCSF, erythropoietin, steroids in general, they're not going to be of much use. They may be detrimental to be when they're going to be used in aplastic anemia. This is what Professor Neil Young has also said. And transfusion requirement, most of them are going to be, many of the patients who end up with us, sometimes they may be chronic low blood count patients also. So try to rationalize according to the patient needs. So unless he bleeds, there's no need of any platelets. And hemoglobin, since is not going to be very much ambulant at this time, even a 6 or 7 grams, depending on the patient fitness, I think that can be tried. Try to continue antimicrobial prophylaxis, whatever benefit is going to give, and as much as possible, try to reduce the hospital visit for transfusion. Next slide, please. Yeah, the other emergencies which we may face in the patients ultimately end up in a hospital. One is ITP, the other is severe autoimmune hemolysis. ITP, the ideal thing is, yeah, steroids are beautiful drugs. We all know that, but unfortunately, if the patient is not in a very severe bleeding symptom or whatsoever, try to spare the steroids for the time being. But if really low platelets, sometimes I got a patient with an IC bleed, so nothing much to be done. I just put them on gram per kg of IVAG for 2 days. But this is again quite a costly affair for many of the patients. So, but this is a good thing. It's a double way benefit thing. Giving IVAG at this point may be of not detrimental, at least definitely it may be of some use. But if the patient is related on an OP basis, try not to admit them unless otherwise it is required. There are even Professor Verma on the day was saying that not only L-thrombopag, there are people who are using the combination of both L-thrombopag as well as weekly thromboplastic. Though there are no data to support it, just to spare the steroids, many people are even using it in those patients. You can always try it. But both of the drugs, especially erythromepac for that matter, after 2 weeks to 3 weeks, many times it just settles the patient's platelets. So I think that's a good idea. Patients who are not affording it, yes, other options like dapsone or low dose cyclosporin, all these things can be used. One thing I'll say is the first relapse patients and all avoid giving rituximab. And one more thing, as I discussed before itself, patient for no previous history, we just as I patient 20,000 platelets, some lymphopenia, we were really worried. Ultimately, dengue turned up to be positive. So it's not necessary that when COVID is around, other viruses should not be here. So always do the routine workups, whatever you want, let it be serology or dengue or whatsoever. But keep in mind, sometimes even COVID also presents with mild lowish platelets, not very low, somewhere in the range of 50 to 60,000 or whatsoever. Autoimmune hemolysis, yes, steroids we have to give, unfortunately, short pulse, maybe azathioprine, both are immunosuppressive. One thing I can say is rituximab, if you think it's useful, you can avoid it, and splenectomies and all those things can be postponed for some more time. Next slide, please. Last in the line is sickle and thalassemias, the hemoglobinopathies to discuss. Sickle, only few part of the country mostly deal with sickle cell anemias. Because I don't know, one thing commonly used in sickle is the pain crisis, where we used to give NSAIDs without any problem. There are a lot of data to say that Brufen has got some detrimental effect with the viral replication. So maybe at this point, you can even go for the next level. Say the pain is really, really tough to things like morphine, or if you can manage, better manage with paracetamol itself. And one more thing which may be confusing when you're sitting in a clinic is acute chest syndrome of sickle patients. Though in India it's not a very common affair, but there are packets where they see regularly. You almost always try to have in back of mind it may be a COVID crisis also. So try to evaluate, take all the preventive steps if you are going to analyze, examine such a patient. Just at the back of the mind, think that I am not dealing with a patient with COVID. Minimal transfusion is always better, or you can always use anticoagulation whenever it's going to be appropriate. Thalassemias, nothing much. Keep your transfusion cutoffs low so that the patient unnecessarily don't come in and out of the hospital. Next slide, please. Yeah, anticoagulation, yes. All patients who are already on anticoagulation, it is a good idea to continue whatever they are on. COVID patients, as I said, needing routine anticoagulation, I really, really don't know. Since data is just building up. So there are a lot of people who are using heparin and Clexane and everything in patients who are having this COVID and getting on into the critical care units. But there is not much of solid data to support the regular use in all the patients for that matter. But if at all there is a thromboembolism in a COVID patient, heparin is something which is kind of okay to continue. There are few of the drugs like antiviral drugs which may have interaction with our directly acting anticoagulants and clopidogrel, so we should be careful of using those drugs. Next slide, please. Transplants, next slide. It's a tough time now, so but because of logistical issues, it is very, very tough at this point in time to do any of this matched unrelated donor transplants. And one more problem, as I said, if we really don't know, there are a lot of patients with COVID being asymptomatic. So there may be some patients who are asymptomatic or donors who may be asymptomatic carriers. So we really don't know. There are no things in place to say when to do a donor testing or RT-PCR for COVID, if at all we are planning a transplant for that matter. There are many centers which don't have in-house storaging or CD34 flow cytometry facilities. They all are facing logistical issues. And one more thing at the end of the thing, I said availability of ICU beds, because general ICUs are getting filled with other patients. So all these things you have to keep in mind. It will be a good idea that except in very choosy cases where you are very much confident about the donors from the patient side, it's not a good idea to take up transplants at this point in time. Next slide, please. Yeah, this one, convalescent plasma. Everybody talks about convalescent plasma therapy now. Sometimes from the desperate colleagues like this advertisement, we may be getting, as a hematologist who run the apheresis services also, we may be getting some requests from the medical colleagues asking for convalescent plasma therapy. So I thought I'll do a fast run through the FDA and ICMR till now what the protocols they have proposed. Next slide. FDA just are saying that there are many papers from China, to be more frank. Now the England people and the Americans have started using it. So this is FDA's recommendation. It doesn't mean that only these patients are going to use. There are a lot of Chinese papers who say that up to day 14 of onset of symptoms, and a median of around day 14 is what, if it is given before, it works well. Though they have used in very critically unwell patients, but there is some ironical data saying that the patients are just going towards criticality it is in them, it is of much use. I really don't know how far it is right to use this convalescent plasma in patients who are not gone into a very critical stage, who are relatively stable, but the use has started to be more from the NHS. Some of celebrities in England are getting COVID and they're treated and going out of the hospital. There are not data, I should say, there are some hearsay saying that the convalescent plasma is being regularly used. Next slide, please. This is how it is. You have to have a patient who is affected with COVID and whose complete resolution of symptoms is there at least 28 days prior to the donation, or at least 14 days prior to the donation. I mean, 14 days he should be kind of symptom free and 2 negative PCR tests should be there. But there is a point of worry here, because in South Korea there are few patients who are told as negative by PCR testing. They are again found to be positive. So we really don't know how far to believe the sensitivity and specificity of the test. We shouldn't be making a disaster collecting a viremic donor sample and giving it to the patient. So that shouldn't be done, but a lot of things need to be worked on. Once the rapid antibody kits are available in India, it will be very much possible to do a neutralizing antibody test. Somewhere the FDA recommends 1 in 160, but a lot of Chinese data says at least 1 in 1000 or 1 in 640 is what they have used when it comes to convalescent plasma. Next slide, please. Next slide.
Yeah.
Yeah. So this is basically the data from the large data from China, which if you compare the left and the right CT scan, this was before and after in 2 patients. Somehow magically in most of the patients, this convalescent plasma with high antibody titers seems to be working. But unless at this point in time, next slide please. Yeah, at this point in time, the ICMR has not given it as a routine thing to use in everybody, but we can, if you really want to start venturing out into this, your laboratory should be kind of equipped to give the antibody titers. Even not now, maybe in the next week or so, they should be ready to give the titers for that matter, and it should be done on a clinical trial basis or not on a regular basis. What they're actually doing is collect around 10 ml plasma per kg of body weight of the patient. That comes to, of adult, to come to around 600 to 800 ml, and every patient needs somewhere around 200 ml. So looks and here's very simple, but we have to keep in mind all the transfusion reactions also that can happen. A lot of other complications, like even the donor becoming positive on a later date, that also can happen. So we have to wait for some more time before we say that we can use this convalescent plasma in all the patients. So to conclude this, yes, I do know that a lot of questions are still unanswered. So this, whatever I've been said, no, these are just a consensus opinion of hematologists practicing across the country and facing this situation. So now, as I said, nothing is wrong, nothing is right at this point in time. The basic dictum is try to keep the patients at home. As said by the government, staying indoors is always safe for everybody. So we are trying to practice on telemedicine, take home-based collection of blood tests. Even if the patient has to enter into the hospital, get admitted, we are trying to make sure that these are going to be short daycare procedures or maximum outpatient-based treatments. Prescriptions and everything can be given for a longer duration, at least for 2-3 months, so that all the not only protecting the patients, we also may be protected from an exposure to unnecessary exposure to COVID patients for that matter. Next slide, please. Next slide.
Yeah.
Last but not the least, yes, we know it's a very crisis situation everywhere. We are hopeful that when it came, I mean, SARS or H1N1 or whatever it is, we have all gone through it and we have come out successfully. I think this time also we will do it. So it's almost always better as because most of you as practicing hematologist or oncologist, you are going to be the boss in that area. So what is your mood actually will get reflected in the mood of all your junior colleagues and staff who are not that much who, I should say, they're more vulnerable easily to get affected by these things. Staff attrition rate in many hospitals have come up to 40 to 50%. So I think it is a duty at this time to have a positive outlook, protect everybody who is around you or dependent on you on the staff side also, and let's make sure that we're not going to set up any panic or a depression chain reaction among the vulnerables. So thank you very much. Next slide, please.
Yeah, I
Thank you very much
think
for the opportunity. Yeah, I should thank the Cadre of Pharmaceuticals for giving me this opportunity.
yeah,
I think this will be recorded and it will be available on the YouTube also for viewing later.
perfect. So would like to ask audience like any queries or any questions or doubt may be there. Then we can take up, certainly few number of questions here. And please write your questions in the chat mode only because we cannot, unmute the microphone for everyone because this is going to be creating the loud noise here. So, won't be able to hear anything here. So we would request like to ask your queries in the chat mode only. On the right side, you may see the chat mode option there, and you can ask your question here. Okay, so like at
Yeah,
the moment we don't any have any no
no
one has
issues, no
asked
issues.
any questions here. No
Yeah.
worries. So